So the first case, this is a 67-year-old male who initially presented to an outside hospital with anacusis and also tinnitus and with balance difficulty. Otherwise, he had no real like focal neurodeficits on exam and no relevant past medical history. So I guess we can ask David, where do you think this lesion localizes to? What workup do you want to do?
Yeah, I think this lesion would look likely the posterior fossa and CP angle. Would want to start with CT scan.
Mm-hmm. Yeah, so here's a CT. Can you tell me, what you see? Are you still there, David?
Yeah,
Doctor, he has like,
So,
Oh, I'm not sure if you said anything. It might have cut off, but so yeah, it's a cystic, lesion with calcification. So we got an MRI next, and so here is the MRI. Can you, describe what you see here?
yeah, so you have a cystic lesion with what appears to be a dual. Okay, this at the left CP angle, which is consistent with their symptoms, diffusion restricting. But on the ADC, actually, that looks a lot more like T2 shine through.
Yeah. So what do you think the differential is?
So in this sort of setting, I would anticipate something neoplastic. So anticipate something like a JPA appears less consistent with something like a schwannomas. Other things to consider, some primary cystic lesions like epidermoid or dermoid cyst.
Mm-hmm.
So it's not an infection or anything like that, unless just having true infectious symptoms.
Yeah, exactly. So, so here are so before I tell you what it was, this lesion was resected at an outside hospital, and then they actually had left residual. We didn't know the pathology because the patient didn't bring it to us, but then he said that he had received radiation to the residual, and then about 7 years later, he presented to us with progressive left facial weakness over the past few months. And then on exam, he was now House-Brackmann 6 and had, stable anacusis, same as before. But, before, right after the resection and radiation, his facial nerve was intact, but it was just like, 7 years later, like all of a sudden he started having this facial weakness. So here is the new imaging. We don't have the pathology report. So describe what you see and, what you think, your differential is based on, the symptoms and stuff.
Yeah, based on the imagery, you have an enhancing lesion that's entering into the left. I see there, let's say there's a residual that's cystic lesion primarily, but it's entering into the ICU, so it suspects something like a radiation-induced distributor schwannoma lymphoma.
Yeah. So here are the so for this patient, so just to go over the imaging findings a little bit. So yeah, so like what you said, it's contrast enhancing, and then here on the T2 below, it's hypointense on T2, which represents probably like high cellularity. And so for just to go over real quick, like acoustics, to describe it is that, the symptoms for acoustics, it correlates with tumor size. So initially, how you see acoustics in clinic, they have hearing loss, tinnitus, and then vertigo is the initial thing that they present with. And then as tumors get larger, they start getting all these other symptoms like headache, facial weakness, numbness, diplopia, and nausea, and vomiting, and change in taste. And so the main thing I wanted to bring up was that, the symptoms from cranial nerve 5 and 7 compression only occur mostly when the tumor is greater than 2 centimeters. And so, with acoustics, we typically think that they, are closer to the facial nerve. And so they distort the facial nerve, more, or they distort the facial nerve sooner than cranial nerve 5. And so we would expect, typically to get facial symptoms before, but we actually get facial like numbness from cranial nerve 5 before facial weakness, just because they think it might be the resiliency of the motor relative to sensory nerves. And so I bring this up because for this patient, the tumor was way smaller than 2 centimeters. And so when you have, things like facial weakness in a small tumor, it's just important to consider, something malignant on the differential. And so here, this patient had actually ended up having a squamous cell carcinoma that was malignant transformation from an epidermoid cyst. And so the main things that I saw, looking in the literature, was that they described it as basically it looked like an epidermoid cyst, but just with a mural nodule attached to it. And so you see here at the bottom, there's a cystic lesion that's, pretty much follows CSF on all signals except for diffusion restrict. So that corresponds with the epidermoid. And then for the squamous cell portion is the mural nodule. And so that portion usually has calcifications, and it's low on T2 due to high cellularity. And then this mural nodule sometimes enhanced, and it'll have this like cystic enhancement, which an epidermoid doesn't normally have. And so what would would you take this patient for surgery? What would you do?
In this case, yeah, since it's a benign lesion, I would take it for surgery. In this case, you go through the old craniotomy site to do a retrostate for approach. Given the size of the lesion and the amount of IC invasion, being more aggressive wouldn't necessarily be indicated. Sorry, you said you had total hearing loss?
Yeah, he had total hearing loss, and his facial nerve functions already has Brackman 6.
Yeah, so you can be relatively aggressive with this. You have to say something like that job.
So yeah, so they, you could do either way, but they ended up doing transcochlear just for, because he had already had prior surgery and radiation. So I guess they wanted to, avoid all the scarring. And so, if the radiologists call you, here's a post-op scan on the right. If the radiologists call you in the middle of the night and they're like, oh my God, you guys left some residual, or there's some lesion in this, area, what would you say? What would you tell them when you saw this imaging yourself? Like, what is this bright stuff right here? Is this tumor that grew back, or is it blood?
I saw the fat graft. That's
yeah.
And
yeah, exactly. So I guess we'll turn it over to Dr. Goltikin now. Oh, Dr. Goltikin, are you able to share your screen? I don't know if I have to
Do you see it?
Yes.
Okay. So the first specimen was similar to what you were describing. It's cystic lesion. You can see the cyst lumen here. You can see the material in the lumen that is squamous debris and surrounded by a relatively attenuated squamous epithelium. This is, just a squamous epithelial, benign squamous epithelial cyst. However, and then you see the close-up view of the cyst contents, which is dead squamous cells, and the squamous epithelium here, which is benign maturing squamous cells. Okay, compare this with this, which was the second specimen. This is the squamous cell carcinoma. You can see on low power that there's an infiltrative element, these dark blue purple islands infiltrating through some kind of background fibrous tissue. Okay, and under high power you can see the atypia. It's fully differentiated. It's difficult to discern the squamous quality of the carcinoma cells. There's pleomorphism, atypia, nuclear atypia, necrosis in the center here. And of course, the whole thing stains with keratin and P63, which are both squamous immunohistochemical markers. The Ki67 shows, an elevated, significantly elevated proliferation index. And that's it. So squamous cell carcinoma arising in, I'm gonna stop sharing. Oh. In an epidermoid cyst, probably. I wonder what the pathology was 7 years ago. Why did they decide to irradiate it? Those are
Yes.
mysteries to me.
Yeah, so the initial pathology, like after the fact, because we found that it was squamous cell, initially when he presented to us, they thought it was an acoustic actually. And so we didn't have the path reports and we took him to the OR, and then the frozen showed squamous cell, and so we requested the records, and then actually the initial lesion was squamous cell already.
I'm sorry, what?
The initial lesion was already squamous cell, like after we had, retrospectively requested the records,
Oh.
he still already had squamous cell in the past.
That's why they irradiated it.
Yeah.
Yeah, this underlines the importance of, requesting pathology from outside sources as soon as you can, right?
Mhm.
Okay.
So this is a malignant transformation of epidermoid cyst to squamous cell, and so intracranial squamous cell carcinoma is relatively rare, and so most of the time it arises from malignant transformation from either an epidermoid or a dermoid, and so they think that the possible causes of transformation is from either chronic inflammation from repeated microruptures of the cyst, or just iatrogenic from irritation after you resect the cyst, which triggers the transformation of the lesion. And so the main point is that you should suspect malignant transformation of epidermoid to squamous cell if patient has a recurrent lesion and there's rapid growth in size of the lesion, and he had progressive symptoms and neurological deficits like facial weakness that you wouldn't expect for something like an acoustic. And so the second case is a 49-year-old male who presented with an episode of diplopia that subsequently resolved, and on exam, his extraocular movements were intact. He had no vocal neurodeficits. When you see him, no relevant past medical history. So I guess is Tyler here? Or Long? Or Imad? Okay, is Adam here?
Yeah. Oh, sorry. Right.
So what can you what workup would you do? And
Can you hear me?
no. What workup would you do, Imad?
Okay. All right. So I've done an MRI with and without contrast.
Okay, so here's the MRI. Can you describe what you see?
Yeah. So it looks like there's some around the right occipital in the post gad with some. Give me. So okay, sorry. So in the post contrast, you see some enhancement around the left anterior temporal, kind of almost like near the sella, I would say.
You said near the where?
I guess like more like cavernous sinus, like enhancement within the cavernous sinus on the left side.
Okay.
Concerning for probably some kind of some kind of mass. I wouldn't think it's like a pituitary. It's not near the pituitary, but there's definitely something in cavernous sinus that looks a little bit irregular in terms of size, but homogeneous and contrast enhancing, and maybe some elements of like like some cystic appearance as well.
Mhm. What do you think that this could be?
Um,
Or just like your differential for like, cavernous sinus
maybe
lesion?
like maybe a schwannoma of some sort because it has like some cystic appearance. Could also less likely to be like a meningioma because I would expect more of a diffuse contrast enhancing without kind of like the cystic components.
Mhm.
So right now I'm thinking more along the lines of schwannoma.
Yeah. So here is just like a little table that I found that I thought was pretty useful. So, there's 4 different, broad categories: neoplastic, vascular, inflammatory, or miscellaneous category. And so if it's like neoplastic and chronic inflammatory things, it'll be more insidious onset of symptoms. But then if it's like some vascular cause or an acute inflammatory process, then you'll have more acute symptoms. And so as for neoplastic, like what you were saying, you have things that come from the cavernous sinus, and so most commonly, meningioma, schwannoma, and you can also have invasion of lesions from the nearby structures into, the cavernous sinus. So for example, like pituitary adenoma, and then you can have like systemic neoplasia that goes there as well as NETs. And so if I give you this, so the one you said before, you thought it was most likely schwannoma. So if I give you the same exact, this imaging here with the lesion in the similar location, what would you say that it's still a schwannoma, or would this be different?
I think this would be different. I think this would probably be more like along the lines of maybe like a meningioma.
Mhm. And why do you think that?
Again, I don't really see like the cystic appearance that I saw in the last one. It's more of a diffuse contrast enhancement, but then it also kind of has, I think, maybe like a dural chill right there in the coronal that I see. So yeah.
Yeah, exactly. And then on this bottom right image as well, you can also see this,
Mhm.
and so yep, you're right. So that's a meningioma. So just to go over it real quickly, like, schwannoma versus meningioma, because they can both be in the cavernous sinus. So the one thing that you didn't mention is for this schwannoma versus meningioma, usually schwannoma is like really soft, and meningioma is more like fibrous and firm. And so when meningiomas grow large, they can cause, carotid stenosis around the carotid. So if you see in the right image, see how this carotid is smaller than the other side, but then for the schwannoma, carotids are the same size. And so the other thing is, schwannomas, typically look dumbbell appearance, like this bottom picture. And like what you said, they're like heterogeneous, and they have some cystic component to it as well. And then for meningiomas, it's more, homogeneously contrast enhancing, and, has that dural tail. And so what, how would you manage this patient? Would you just observe them, do radiosurgery, microsurgery?
I think because they're starting to have symptoms, especially even if it's transient difficulty, I would start moving in the direction of probably some kind of management like surgery or either radiosurgery. I don't know if it would be. I don't know if I'd observe in this situation. I think.
Yeah. Do you? I guess we can bump it up. Damien, would you do radiosurgery or microsurgery? If you did microsurgery, what approach would you do?
Yeah, I mean, I think given that he's starting to have symptoms, I think microsurgery is probably a good option at this point, because as the tumor grows, it's only going to get harder to resect, especially if it has worsening symptoms. I think a couple probably different approaches. You could do probably like a subtemporal approach to get to the cavernous sinus there, given that it's more posterior as opposed to being like doing like a cronidectomy coming from superiorly.
Mhm.
That might be harder to reach backwards. to get the stuff in the cistern.
So yeah, so that's what they did. They did a middle fossa craniotomy, and then they peeled, from posteriorly to anterior so that they don't avulse, the GSPN from the geniculate, and then they went in between V2 and V3 intracavernous to resect the lesion. And so, they were able to get all of the trigeminal schwannoma. So the other thing I wanted to ask is, okay, so if so earlier Imad was saying that this one was an intracavernous meningioma, this other image that I gave you for a different patient, so if I gave you this image, would you still do surgery, or just watch it, or for intracavernous meningioma, not a schwannoma?
For this one, I think it's really increasing the carotid in this situation. I think I would, I think I would still, I would observe to see if it's kind of continuing to grow, not symptomatic. It would be probably like a difficult resection, but observe and then see how we can see if it continues to grow.
Yeah. So for the schwannoma, like I was saying before, it's like soft and suckable. So, it's reasonable to go in and resect the lesion. But for meningiomas, because it's more firm and usually it's not as suckable. And so if you go in to the cavernous sinus, you can cause, ophthalmoplegia. So people typically just watch these lesions, and if it grows, then they would do just radiosurgery, unless it's lateral to the cavernous sinus and just adherent to the lateral sinus cavernous sinus wall, then that's when they would take it out. But if it's actually intracavernous, then they typically just do radiosurgery. So we'll turn it over to Dr. Gultekin now.
You guys see?
Yeah.
Hello?
Yes.
Okay. So, about your last comment, I have seen a couple of cases of cavernous sinus meningioma that had atypical features on biopsy, but somehow ignored and got out of control through the years. So, I think careful consideration should be given to early stereotactic radiosurgery in those cases, depending on if you have initial pathology at least. If it's benign, then watch it. But, atypical meningiomas can happen there too. So anyway, this was not a meningioma. This was a schwannoma. And you can see on low power here, this big amount of tissue given as cavernous sinus lesion. I'm not always used to getting big amounts of tissue, so that was good. And it's a spindle cell lesion, essentially a low-grade spindle cell lesion. On low power, it looks homogeneous. Schwannomas typically have tighter and looser areas called N20A and N20B respectively, but this doesn't have N20B. Intracranial schwannomas typically do not have a lot of loose areas, N20B, but more systemic examples are biphasic like that. On high power, you can appreciate the spindle shape of the individual nuclei, and they don't look so enlarged. They're generally low-grade looking or benign looking. And you can see what we call this Verroque body, which is palisading of nuclei, tumor cell nuclei, schwannoma nuclei on either side of this nuclear-free zone, where you can see the processes of the schwannoma cells crossing like this. So there's another one right here. So just get used to this if you think that this is going to appear in the boards. Okay. And lastly, schwannomas can have a lot of blood vessels, hyalinized blood vessel walls, like pink blood vessel walls that lost their smooth muscle cells. And of course, in this case, you don't see it, but there can be a lot of cystic changes, other degenerative changes, macrophages, hemosysteine deposits, etc. Eva asked me to compare schwannoma histology with that of meningioma. Meningiomas have more plump, round nuclei. They have whorls. You see these meningioma cells kind of wrapping around each other. They have nuclear pseudo-inclusions, optically empty spaces within the nucleus that are invaginations of cytoplasm. And they can have, of course, some MoMA bodies over here and here, concentric calcifications. So pretty different. Sometimes in the posterior fossa, you can see a fibroblastic meningioma, which may be similar in morphology to a schwannoma. In that case, sometimes in frozen sections, I say low-grade spindle cell tumor, schwannoma versus meningioma differ to permanent sections because I am unable to tell during frozen section, and hope that it's not going to make a difference in surgical decision making, but that's rare. I think that's it for this case.
Yeah, so like Dr. Goltikin said, this is a trigeminal schwannoma, and so schwannomas, they're benign, they originate from Schwann cells, and so they make up they're really rare in the intracranially, so make up about 0.1 to 0.4% of intracranial tumors, and so they most commonly occur in the 4th decade of life, and in females more commonly, and they present with trigeminal nerve dysfunction like pain and numbness in the trigeminal distribution, and so with trigeminal schwannomas, it can arise from either the cisternal segment or the Gasserian ganglion or the divisions at like V1, V2, V3. And so, there are several different classification schemes and like Jefferson, Dave Fukushima, Sammy, Romina, but all of them are, kind of similar. They just categorize it a little differently. And so just to go over real quickly, for Jefferson, it was the first one that was discovered in like 1953. And so they just classified the trigeminal schwannomas into 3 types. And so type A just means that it's arising from the Gasserian ganglion in the middle fossa. And then if it's type B, then it's arising from the cisternal segment in the posterior fossa. And if it's type C, then he described it as a dumbbell shaped, and the tumor would go into the middle and posterior fossa. And so then later on, Day and Fukushima added a 4th category called peripheral category. And this was just to describe the trigeminal schwannomas that arise from V1, V2, V3. And so you can see here on the picture on the left, class A is when it arises from Gasserian ganglion, class B is when it arises from the cisternal segment, C is when it's dumbbell shaped, and D is when it arises from V1, V2, V3. And so here, the main thing about classification schemes is that it helps to kind of determine what surgical approach to do. And so you can see on the left, I'm not going to go through the whole thing, but like if you have, for example, D and it's mostly in the posterior fossa and nothing in the middle fossa, then you can just do a retrosigmoid, versus if you have like the dumbbell shaped one in the middle and posterior fossa, then you can do a combined putresectomy or like a 2-stage retrosig followed by a middle fossa approach. And so the 3rd case, this is a 41-year-old female who presented initially with had 2 weeks of blurry vision, and then her vision acutely worsened in her left eye 2 days ago. And on exam, her left eye was 2800, on the right it was 25, and she had a left monocular temporal hemianopsia. So I guess is Tyler here? Okay, is Long here? Or Adam? Okay, or Turkey?
Yes, Eve, I'm here.
Oh, so what workup would you want to do? Where do you
Yeah,
think
so
the lesion is?
Yeah, I mean, given that this is an acute onset of, predominantly left vision blindness, first of all, I would, do some basic lab workup, hormonal workup, and ophthalmological, official workup, and then MRI just to make sure there's like no cellular lesion. That's my initial workup in the meantime.
Mhm. Okay, and then here is a CT. Can you describe what you see?
Yeah. So CT without contrast, coronal and sagittal. It shows that there's I believe, an empty cella. Um, I don't see any lesion. I don't see any expansion of the cella turcica or bony erosion. Um, yeah, so mainly, the empty cella, and also she has like small ventricles. Does she have any headaches by any chance, Eva?
No.
Okay.
Yeah.
All right.
So, is there any other, workup you want to do given, this imaging or additional imaging?
Yeah, I would like to do an MRI of the brain
Okay.
without
So,
contrast.
and so this is actually it's a little hard to tell. I know it looks like an empty cell, but actually this is it's a cystic lesion, which I'll show you on the MRI in a second. And then here's like some calcifications here.
Gotcha.
And so, because it's a cellular lesion, if it's a cellular lesion, what, other workup would you want to do? What kind of
endocrine.
labs, yeah.
Yeah, full endocrine panel, and also official ophthalmology,
Mhm.
consult for proper visual acuity
Mhm.
assessment, and fundoscopy for any papilledema.
And what like pituitary labs would you get?
I would get growth hormone, prolactin, FSH, LH, TSH, free T4, and insulin-like growth factor, IGF.
Yeah. Yeah. So the mnemonic is just for the juniors and some like flat pig as the mnemonic they usually have on step. And so here's the MRI. Can you, describe what you see here?
Yeah, so this is a coronal MRI with multiple sequences, T2, T1 without contrast, sagittal with contrast. So I can see on the coronal T2, there's a hyper intense cellular lesion with, it's severely compressing the inferior component of the optic chiasm. On the sagittal MRI, I don't see that lesion very well, but it's not enhancing, that's for sure. So it's mainly a cystic lesion. I would honestly do an angiogram just to make sure it's not an aneurysm.
And where do you think, if you look at this, where do you think the pituitary is?
So the pituitary is actually posterior to the cellular lesion. You can see that there is enhancement of the neurohypophysis, which is the posterior pituitary, and the stalk as well.
Okay, and so what do you think is the this? Can you see my mouse?
I do.
Oh, okay. What do you think is this? Is this the lesion or is this pituitary? What is that?
No, that's the pituitary.
Okay, yes, yeah, exactly. So yeah, this is a pituitary, and then this is a cystic lesion. There's like, a little bit of enhancement here, which could be, enhancement of the cystaps or part of the stalk. And where do you think the optic nerve? So its optic nerve is right here.
Yeah.
So what do you think is the differential?
So differential diagnosis could be, it could range from Rathke cleft cyst, cellular craniopharyngioma, which is not common. Usually it's supracellular. It can be an aneurysm, even though it's very uncommon, but can present, it can mislead someone like this. So these are my main three differential.
Okay, so yeah, so I mean, this is the mnemonic, like SACHMO. So like what Turkey was talking about, craniopharyngioma, Rathke's cleft cyst, especially since it's like it's so this lesion is supracellular. It's not expanding the cella, and so it's less likely to be like a pituitary adenoma, which arises from the cella and, more commonly causes expansion of the cella. And so, what would you do for this patient?
I would, first do an angiogram just to make sure it's not an aneurysm.
Yeah, they didn't do an angio, but
Okay.
yeah.
So yeah, for the, I mean, she definitely needs surgery given that she had, 2-day onset of vision loss, acute vision loss. So the approach to this lesion, given that it's a predominantly cellular lesion, anterior to the pituitary, superior and anterior to the pituitary and the stalk, I would do an endoscopic endonasal approach to resect the lesion. And it's not going lateral to the carotid, so it's pretty favorable for an endoscopic approach.
Yep. And then, so if this patient came in on like a Saturday at like 4 a.m., would you wait until Monday to do it? What is the timing of the surgery?
No, it's going to be an emergent surgery, given that she lost her vision in almost her vision in 2 days.
Yeah.
So she may even be blind if we wait, a day or two.
Yeah. Okay. So yeah. So exactly like what you said. And then, the goals of surgery, just, diagnosis, decompress the optic chiasm, and the cure if you're able to get it all. And so we did an endoscopic endonasal approach. They were able to get all the lesion. You can actually see here on the post-op imaging, the pituitary gland is actually re-expanded now. It's no longer compressing on the optic chiasm. And so the other thing we wanted to talk about was like, because this was a craniopharyngioma, but for craniopharyngiomas, they involve the pituitary stalk. And so it's just really common for them to get like panhypopid after surgery. And so it's just important to like keep an eye out on that. And so we'll turn it over to Dr. Goltikin.
So yes, this was indeed a craniopharyngioma. On this low power, you can see the, essential elements of the craniopharyngioma. There is the basaloid epithelium, which is dark purple here, which I'm going to show you on high power. There are the ghost keratin whorls like here and here, which are essentially dead squamous cells with a very characteristic appearance, which is also called wet keratin. There's the calcifications, and then there's the stromal elements and, reactive changes and inflammation and all that. So here's the diagnostic picture of, again, the ghost cells. You see the stacks of keratinocytes with no nucleus here. So these are dead and mature keratinocytes. Okay. The smaller cells are more basaloid cells, and there's the calcification. Here's another view, the ghost keratin over here on the right, calcifications on the left. Basaloid epithelium with palisading here is over here. So this is an adamantinomatous subtype of craniopharyngioma, which another good example of basaloid epithelium. Basaloid means it's similar to basal cells of the skin. Okay. This was negative with BRAF and positive with beta-catenin, which means there is a beta-catenin or CTNNB mutation in these cases. The BRAF is more mutated in the papillary form of craniopharyngioma, which this is not. And again, Eva graciously asked me to compare the morphology of Rathke's cleft cyst with that of craniopharyngioma. Here you can see that Rathke's cleft cyst has distinctly ciliated epithelium, columnar, sometimes cuboidal, sometimes squamous metaplasia, and of course has nuclear-free proteinaceous material within the cyst, which you don't really see here very much. but you can see the distinct ciliated epithelium. Okay. That's it for this case.
And so, yeah, this was a craniopharyngioma, like Dr. Goltikin was saying. And so craniopharyngiomas usually arise from residual cells of the Rathke's pouch, and they have, solid cystic components. Like Dr. Goltikin was saying, it's typically WHO grade 1, and they have a bimodal age distribution. And so when they occur in the young and, the older age people, and so when it occurs in the younger people, it usually is adamantinomatous histology, and if it's in older patients, it's papillary histology, which you see here on the right. And so for the craniopharyngiomas, for adamantinomatous craniopharyngiomas, they usually have the beta-catenin mutation, and then for papillary craniopharyngiomas usually have BRAF. And so this is, important because it can guide, further treatment. And so there's this one paper that found, just based on the MRI characteristics, they say that you can actually determine if it's a papillary versus a adamantinomatous subtype, without even getting histology. And so they say that if it's a lesion that's completely suprasellar, and it's, spherical looking, predominantly solid, not much cystic component, and it's homogeneous enhancement pattern, or if the pituitary stalk is thickened, if you have 3 of these 5 features, then it was likely to be a papillary histology with BRAF mutation. And so this is what you see here on the right. And so here, our patient had an adamantinomatous. So you can see here, it didn't have any of the features of, it had it was suprasellar, but, it wasn't really spherical as much as the other one. It wasn't predominantly a solid thing. This one has a cystic component and calcifications. And so the importance of this is that, if it's a papillary craniopharyngioma, because it has the BRAF mutation, it actually responds to BRAF and MEK inhibitors. And so you can see here on the right that, with these inhibitors, they can actually have, decrease the size of the solid component as well as the cystic component as well. And so this is the last case, a 72-year-old woman who, presented with a few months of worsening pain around the left eye. On an exam, she's 2020. Yes, is Victor here?
Yeah.
What do you want to get imaging or?
Listening pain, yeah. So just rule out she's had no other past significant trauma history and basic labs, but outside of that, you can start off with a CT scan.
Yeah, so here's a CT.
And these are all bony windows of CT demonstrate there was a left-sided as lesion that is eroding the superior orbital rim.
Yeah, and it looks like it's a lytic lesion, like what you said. There's these little septations here as well that you see. So the next thing we got was an MRI, and so just describe what you see here.
So similarly, T1 sequences, T2 sequences shows this non-contrast enhancing lesion, and that looks almost cystic in nature.
Yeah, and then here again, on the top right, you see these little septations as well. And so what is your differential for a lytic bone lesion like this?
For these types of lytic bone lesions, you can think of primary bone tumors, such as osteomas, all the way to the malignant ones.
Okay, yeah. So here is just a little mnemonic that I found online for lytic bone lesions. And so this patient, was the main differential was aneurysmal bone cyst versus giant cell, or fibrous, dysplasia, or chondroblastoma / chondromyxoid fibroma. And so what would you take the patient to surgery? What approach, or how would you manage the patient?
She presented primarily with eye pain without any visual deficits.
Yeah.
So I guess there's an argument that it is not an emergent surgical diagnosis at this point in time. But nonetheless, there is something there, and for further management, at least knowing what it is would be of some benefit. So I suspect you could either continue to watch with serial imaging when clinical exam, or you could perhaps decide just to proceed with surgery to at least obtain diagnosis, if not a resection.
Yeah. So like what you said, initially they had watched it, but then, later on the lesion actually grew. And so that's why even though she had no like vision issues, they ended up taking her to surgery. And so we did this through an eyebrow incision and just drilled the part of the sphenoid and then the orbital roof as well as the lateral wall of the orbit, and then used a mesh to reconstruct it. And so we'll turn it over to Dr. Goltegan.
This case is a little strange because the pathology material that we have and the pathology diagnosis, I'm not sure if it's complete or satisfactory for the lesion, but because it really doesn't show most of those entities that you mentioned. There are some, there is bone, there is some maybe cystic space in the bone, which seems to be a dilated capillary here. More of that stuff over here. It really does not look like an aneurysmal bone cyst to me. Certainly not chondromyxoid fibroma or chondroblastoma. It has no chondroid elements. There's these thick fibrous balls, which some of them could be, again, blood vessels. So I was thinking maybe could it be a osseous hemangioma in a way. There's a small spindle cell component here on the side, which again remains a little bit undefined. It wasn't my case. I just looked at it yesterday, and there is some brain tissue. I don't know. Did they go into the brain during surgery?
So, we didn't intentionally go into the brain. It was just that when we got in, the dura was already like eroded through by the tumor, and so we could see brain already.
So there was
some
some
part of
stuck
it.
area that you took out, or?
Yeah, it was just adherent to the the dura that was remaining there, and so we just kind of scooped whatever was in that.
I see.
There was some material that was in the cystic space that in that eroded in the bone that had eroded, and so we just scooped that out and sent it to pathology.
And how big was the lesion?
It was like only like less than 2 centimeters. It wasn't very big.
Centimeters. Yeah. and
Only
if
1.5.
Everything was given to pathology. My colleague, Dr. Saad, didn't think much of this. He said it could be an encephalocele based on this brain, irregular looking brain tissue that was attached to it. The bone, again, does not really show what we're gonna compare here as aneurysmal bone cyst, which consists of blood-filled large cavities with what we call purple bone around it, or chondromyxoid fibroma, which are these stellate cells in a myxoid chondroid background. So I wasn't really sure. If I had the case, I would have sent it to bone and soft tissue pathology, which could be done. If you guys think that this is important. I think ABC is an important diagnosis, but there are unicameral bone cysts which are more benign. There are, again, hemangiomas of the bone which can be seen sometimes. So I'm not sure what this is. This is kind of falling out of my expertise area for a definitive diagnosis, unfortunately.
Mhm.
Yeah, I just realized it yesterday that, this was a bit of a controversial diagnosis. What did you guys think radiologically?
We thought it was an aneurysmal bone cyst, most likely.
Yeah, this really does not fit that.
Mm,
So, and it's benign.
mhm.
I guess this is gonna be inconsequential because of its benign nature and because of the fact that you guys did, gross total resection. But we could send it to Dr. Rosenberg in-house
Mhm.
to see what he thinks. Happy to do that.
Okay.
All right.
And so, initially we thought this was an aneurysmal bone cyst. And so they're benign lesions that are, expansile osteolytic lesions that contain thin walled blood-filled cystic cavities, like what Dr. Goltekin was mentioning. And usually it has this like honeycomb appearance that you see here on the right. And so it typically occurs in patients less than 20 years old in the first 2 decades of life. And most common site is in long bones and in the pelvis, and it's rarely in the skull. It's like 2 to 6%. And so I think there's two main mechanisms of origin, and so it can either be primary and arise de novo, or secondary from another osseous lesion like giant cell chondroid myxofibroma. And if you remove it completely, it's curative. And so that's the end.
Thank you, everyone. My name is Victor. I'm one of the residents here presenting Grand Rounds today. Please, this is a talk about something that I've had an interest in for a while prior to even getting to Miami. So if you have any comments during it, I think it'd be great to hear them as I try to introduce this idea, meta-analyses in neurosurgery, trash or treasure. And it really is summarized by these following figures. And I think it will really hone down why I think this is an important topic. Meta-analyses in the literature are growing. You just have to look at PubMed and you can just count how many meta-analyses and systematic reviews are there. It's I think with the advent of electronic academic literature, I think it's just blossomed due to many reasons, including accessibility. Meta-analyses don't necessarily require you to have raw data. As long as you have access to electronic data, you can actually proceed to do this. More specifically within neurosurgery, you can see that jump is perhaps maybe, I'd say 5 years after the rise of meta-analyses, where people really started to pay attention. And again, a similar curve. And just to prove the point, even within spine, spine itself has also experienced this massive jump in the last 10 years. So, these types of studies, what are they? What's their utility, and where are we going with them? Is the primary crux of this talk that I want to give. Really just to make us better, to give us a better idea, and hopefully everyone out there a better sense of what these studies are, what they can do, what they can't do, and to really ultimately ask that question: are these trash or are these treasure? And truthfully, it will be in the eye of the beholder. The more you know, the more you see. I think the better sense you have of what these studies are and what these studies do. So, just quickly, the outline for the talk: we'll just introduce concepts. We'll compare them to the more well-known studies that we have here. Some interpretation pearls that I really worked on a lot prior to coming here, and really just asking, what is the value of these studies, especially to people that are in the operating room rather than at a desk for most of the time. So just introducing the basic concept first of systematic reviews and meta-analyses. What are they, and where do they fit in with the whole broader sense of the literature? If you were to imagine all literature reviews, which I'm sure we've all done in the past, are this big green circle here. Systematic reviews fall within that. Systematic reviews are literature reviews in the sense that they look at the literature, but they do it in a systematic way. You could argue that a literature review does not require to hit all the key studies, but rather they just have to give a broad overview. But a systematic review is one that systematically, through various search mechanisms and criteria, and the PRISMA guidelines, you can really highlight all the relevant studies to your specific question, which we'll talk into. Meta-analyses then lie kind of within the systematic review circle. Once you've identified all key studies to any sort of question or topic, meta-analyses are then analyses of the metadata. You know, this is raw data that's been collected elsewhere that now is defined as meta data that is then looked into, and we'll go into what exactly they try to achieve there. The one thing I'll point out is I purposely overlapped meta-analyses in the literature review, the green and the blue outside of the orange, to highlight that, you know, meta-analyses are possible anywhere. You don't have to have a systematic review component. It's just that with the meta-analyses, the assumption is that all the data that you're analyzing has been systematically identified and nothing's being left out. Although and so if you haven't done the systematic review, you can still do the analyses. It just may not be as robust when you evaluate it. That rarely happens, though, from what I've seen. And the reason we do this is quality of evidence. You know, we live in an era of evidence-based medicine where everything has to be of the highest quality for us to translate into clinical practice. And so I guess in medical school, we were all taught this, that systematic reviews and meta-analyses lie at the top of the quality of evidence pyramid that you can see here. But truthfully, I really love this diagram that I found later on that shows even within the highest level, level 1 and level 2, meta-analyses also differentiate and dichotomize between higher quality systematic reviews, meta-analyses, and lower quality systematic reviews, meta-analyses, based on what studies they incorporate. And so clearly the highest level you can have is a meta-analysis of homogeneous randomized control trials. But, you know, what we often see, and mostly in neurosurgery due to the difficulties of doing these randomized control trials, is this level 2 kind of evidence. So it's a nice little point and a niche to highlight that not all of the studies that you see in neurosurgery are actually of the highest level of evidence when considering the rest of evidence-based medicine. And so a lot of these systematic reviews, meta-analyses come from this format of a PCOS question. I think this is the best way to really just introduce the concept of a population intervention comparison outcome and study. You really try to frame a lot of the questions based on this, and then you can really start to evaluate the literature. And so in this example here, that was one of the earlier pieces I did in Spine, you can see that for this paper, looking at a locking standing alone versus anterior construct in disc ACDFs, the population were, for example, all the 2-level ACDFs. The intervention of interest was these locking standalone cages. And the comparison or the control would be the anterior plate that we're more familiar with. Outcomes included a variety of clinical outcomes you see there. And the study types we included here were observational cohort studies. So in this situation, this would not be the highest level of evidence. It would be, you know, the lower tier of systematic reviews, meta-analyses. And if you read a paper, you really want to try to identify what the PCOS question is. The clearer the question, just like with any sort of paper, the more robust and relevant the findings are. And, you know, at a good point, you know, what do systematic reviews and meta-analyses do? I think we see them a lot in the literature. Some people will talk them up more than others. And there are many reasons we do them. They aggregate cohorts. So in very rare diseases and conditions that are not robust enough to do analyses, these types of studies aggregate cohorts. As you can get a bigger number, they inform practice. This here, I'll show you on the next slide, is a great example of how a meta-analysis actually led to the withdrawal of this COX-2 inhibitor. And they identify gaps in knowledge. Systematically, you look through the literature, and then with the meta-analysis, you can then identify the certainty of findings. And then as a result, if it's not very certain or there's not insufficient data, you've identified a gap in the knowledge for further research. And in my mind, these papers really are designed to evaluate quality of the current literature. I think it's a common misconception that these studies are designed to compare A versus B, in the sense of to be the definitive answer of clinical questions. And we'll go a little bit more into that as we look at examples. And truthfully, what can these systematic reviews and meta-analyses not do? And they can't create new conclusions. You know, if 10 papers all indicate that approach A leads to better results than approach B, you know, the systematic review meta-analysis is not going to show the opposite. And they're truthfully not going to improve the quality of the current literature. I have this little trash can here, and I've seen reviewers say trash in equals trash out, which is very blunt of them, if I have to say. But nonetheless, it's an example that these studies don't improve the quality. If quality is not so good, putting it together still means the quality is the same. And so just quickly, a great example, and I think we use this a lot when I'm looking into the importance of these studies is, what can these studies do? And ultimately, you want them to inform practice. In neurosurgery, we want them to inform neurosurgical practice. But in 2004, in the Lancet, this group here looked at this particular drug, this particular COX-2 inhibitor, that was used primarily for pain and arthritis. And, it really came out in 2000 that in this GI study, that this COX-2 inhibitor was leading to a lot of cardiovascular adverse effects. So in 2004, by the time they published it, they looked at all the randomized control trials, the highest level of evidence, and they actually found that it was a significant increase in MI risk. Not only that, their findings when they delineated between before 2004 and after 2004 shows that this drug should have been withdrawn several years earlier. It was this year in 2004 that Merck actually withdrew the drug. There was sufficient, accumulating evidence that the risk, the cardiac risk of this drug was too great. And it was this study that really led to Merck having to actually take it off the market, which really goes to show that if you can ask the right question and have the right data, you can really actually inform practice to the point of withdrawing drugs from the market. But specifically within neurosurgery, there are issues that we face, and I really hope to go over these examples moving forward. That not all topics can have systematic reviews, meta-analyses done. Just because there's a question of a question doesn't mean that it's appropriate to collate the literature and do statistics on it for the sake of doing it. And more importantly, not all of these are done correctly. I think that's an important thing to keep in mind as we go through all these examples. And I have examples of things that I've been part of that have not been done correctly that I'll show you. And then the next point is not all topics need to be performed. I think that is more reflective of the publish or perish kind of attitude within academia, that something unique does not necessarily mean that it is of clinical relevance. And we'll talk a little bit more. This is a little exercise that I think really demonstrates how systematic reviews, meta-analyses are different to our traditional cohort studies. This is an example in spine that I did with a colleague of mine. And what we did is we simply just looked at the literature, and we looked at the 30 most cited clinical studies, those 30 most cited meta-analyses on minimally invasive spine surgery. And we just wanted to compare the features of these studies using bibliometric. And so we used Web of Science, and we collated this, and straight away you can see there are differences. They're all statistically significant. Clinical studies had more citations, both overall and per year. They also had less authors than meta-analyses, and they tend to be published earlier, which would make sense. Meta-analyses need these studies to be generated. So first of all, you can see that meta-analyses don't necessarily correlate. And what you look and you find really interesting, at least within the spine literature, is this huge difference in where these studies are coming from. When it comes to clinical studies, cohort studies, the vast majority of the spine papers are coming out of the US, as you can see here. But if you look at the meta-analyses on these topics, the most are coming out of China. And then this generates all sorts of questions. That at least with the Chinese results of the meta-analyses within spine, the data is more accessible, and for these researchers than the clinical stuff is. But nonetheless, again, these studies even differ in terms of where they come from. And the consequences of these findings show that, at least in the areas of minimally invasive spine surgery, citations are less, authors are more, and more meta-analyses are coming from China than the US. And so it really just, I think, quantitatively highlights how these studies are different. And so you should never really interpret them as the same, apples to oranges, so to speak. And so, truthfully, I think what's going to make us savvy readers and identifiers of what is trash and what is treasure, for want of a better word, is to know what to look for. And you know, I've been fortunate enough to be involved in you know, generating these commentaries and reviews as to, you know, what to look for, both within neurosurgery, spine, and biomarkers themselves. And so I'm drawing on a lot of you know, what we've been able to put out there for this, and it really boils down to our four pearls to interpret modeling, certainty, heterogeneity, and bias. I think understanding these four concepts and how they can be used in a neurosurgical systematic review meta-analysis really will help all of us understand how good a study is, how not good of a study it is, and how much to rely on the findings for our interpretation. So looking at Pearl 1, modeling, I'll be using spine examples for this one. Modeling, the Pearl here is to rely on random effects modeling more than fixed effects modeling. And you'll see in a second what exactly the consequences of this are for appropriate outcomes. But just quickly, modeling in meta-analysis refer to the statistics used, and ultimately it's the confidence you have in how similar or not similar the individual results are. On the left, you can see fixed effects model, and what this shows is the confidence you have in the reported outcomes, and this confidence is measured by this black line all towards the overall average. And with a fixed effects model, you assume that every value in every study is perfect. It's almost as if the study was done 12 different times by 12 different people, but with the exact same protocol and the exact same surgeon. Really then meaning that we're truly confident in each and every one of these results that are reported. As we all know, within surgery, that's hard for that to be the case. Surgeon differences, surgeon practice, timing, all differ. And a random effects model takes that into consideration. What that does is it gives you less confidence per result, meaning that when you pull it all together, your confidence, as you can see by this curve at the bottom, the distribution of the underlying is much wider. It means that if we assume that not every center and every paper is done the same way, it means that we're not as confident when we pull the results together as to whether or not it's actually truth. What this means is that when you do an analysis and you find that the result is statistically significant using a random effects model, you're saying that the result is actually significant, assuming that everyone's done it differently, which truthfully means that the difference or whatever you're looking at is likely significant. If center A does it one way, center B does it one way, and they both find the same result, it means it's probably independent of center A and center B, and rather the effect is true. This is not the same to be said for fixed effects, and you'll see what this means here. For this paper here, the bad example is probably just a very loose way of terming it. We looked at multi-level cervical disc disease, and we looked at, you know, this concept of hybrid surgery that I can highlight in a later slide versus ACDF. And you can see here that in this, this is just one example. We looked at operative time, and we compared the operative time of hybrid surgery to ACDF. And you can see that overall, there was a significant difference, and that's highlighted by this 41 value at the bottom. But you can see in the red box, we've used a fixed effects model. So if I was reading this paper now, and when putting this talk together, I'm looking at this paper, you look, if you know what to look for, and you look at the fact that, you know, we used a fixed effects model, you realize that more likely than not, if we had used a random model, this result would be non-significant. And so the consequence of this is actually, you know, impressive, because on one hand, depending on what model you use, the findings are going to have a p-value less than 0.5 or a p-value greater than 0.5. And if you're not aware to look for it, you're just going to assume it's significant. I would argue this, looking back on this paper now, that if we used a random effects model, which is more appropriate, this finding would not be significant, and the conclusions of this paper here would be incorrect. And this is just one example as I continue to learn all of this, you know, how this is different. And so it's important to, you know, when you look at these papers, to look at what type of model they used. And to be honest, when you use a fixed effects model, there should be some justification in the paper. This is a good example, for want of a better word. This is a paper with Dr. Wang that we looked at endoscopic decompression of lumbar stenosis. And what we did is we looked at endoscopic decompression versus minimally invasive decompression. And here you can see we used a random effects model, which is in the red box here. And you can see now that in terms of functional outcome, when you really look down to it, it was non-significant. You can see the p-value was 0.22. And this shows, and when you read this now, you'll understand that, when you compare endoscopic to minimally invasive for this type of pathology, the functional outcome is not significantly different. And I think that's important to note. And that's only because we used a random effects. If we used the fixed effects and did this again, we would actually show that there was a difference. We would say it favors endoscopic over MIS. But again, truthfully, we're not doing us any justice by using a less conservative model, in my mind, especially given that the number of contributing papers is so low. So again, this here is an example of how using a random effects model does not show us a significant outcome, but more likely a more reliable and relatable result. The next poll is certainty, and I'll be using a pediatric examples for this one. And it's really to seek certainty assessment for each reported outcome. If someone was to ask me to summarize what I think the primary goal of these reviews are, I think truthfully it's to evaluate certainty. I don't think it's actually designed to answer a question. It's designed to tell me how certain is the literature in a particular outcome. And you'll see how this may be of significance. The typical grading tool, and I hope that every time you read a paper, you look for this tool specifically, is called the grade assessment. There's in my mind now, you need to have a grade assessment for it to actually be a relevant paper. And grade stands for grading of recommendations, assessment, development, and evaluations, which is developed by the same Cochrane and Prisma group. And what it does is it really looks at 5 domains here: type of evidence, quality, consistency, directness, effect size. And it really, as you can see in the caption below, tries to quantify and give it different values based on, how each contributing study to the overall outcome is in terms of that. So complication, and what it does is it's for every outcome. So complication, the summary statistic is the risk ratio, and for length of stay, it's a mean difference. And ultimately, when you do this, and then you look at the very end, it's designed to give you a degree of certainty. And you can see you can have a very low and low, and at the bottom you can see how many points you need to actually get to high certainty. And for example, in this table here, the complication outcome is of very low certainty. So there were 6 studies into it, but the certainty of the result is very low, versus the length of stay difference was low. And what that means is that when you look at these outcomes and you try to quote these papers and say that this meta-analysis showed this, it's really showing you how certain you are in the result, because it can show a significant difference between 2 things, but if the certainty is very low, it's very hard to then be like, this is the actual reality of things. Ultimately, certainty is highest when it's most randomized data that is performed consistently, which then goes back to our initial pyramid, showing that grade 1 level of evidence was involving randomized controlled trials. In neurosurgery, you rarely see that. So in neurosurgery, truthfully, in neurosurgical systematic reviews, meta-analyses, the certainty tends to be low and very low, which is, I don't think, a point stressed enough when we create these papers and set it up. So this is a bad example. I would say this is one of the earlier examples we did in pediatrics, looking at the addition of duroplasty to decompression for these Chiari malformations. And you can see we found a significant number of differences, overall clinical improvement, length of stay, complications. And then we also made comment on revision surgery, blood loss, searing, scoliosis improvement. And we have all these numbers here and all these p-values, but this paper does not tell you how certain things are. It does not tell you, whilst the addition of duroplasty leads to overall clinical improvement, it doesn't tell you how certain it is based on the current literature. And I think that's very important to note. You can't have, the gravitas to go ahead and argue a single point in these types of papers without knowing the certainty. And so, this paper here, we didn't do that. And I think, going back, I would definitely have done that. a better example would be this recent paper we did with Dr. Raghu, Dr. Wang, looking at repeat surgery for pediatric epilepsy, be it disconnective or resective approaches. And you can see that here we've included the grade table. And not only that, we've also found a certainty that's moderate, which, you know, I don't typically have seen when I put these tables together. And you know, this study showed that for those people that have failed or still remain symptomatic after the first initial seizure surgery, at least around 1 in 2 or half of them would benefit from a repeat surgery. And we had 11 studies here, and the certainty was moderate. And so it allows you to go ahead and at least discuss the option of repeat surgery, both with colleagues and also with patients, with a higher degree of knowing exactly how reliable this data is. And so, you know, this is an example of certainty being used in a neurosurgical meta-analysis, which is better in terms of being able to understand how applicable the results are, and something that, you know, I hope people continue to look for in their studies. The next pearl to mention is heterogeneity, and it's having the papers recognize that all studies are different. You know, ultimately going back to what we said earlier, center A might do something different to center B. And if you don't account for it or don't try to at least acknowledge it, results and the interpretation of how reliable they are get skewed. And so we'll use some pain examples here for this. And this is, you know, this is what I'm talking about, just pictorially. Example A is this sense of heterogeneity is also, you know, reflected in the confidence interval of these studies. And example A is recognizing that even within studies, within papers, within cohorts, there's heterogeneity. You know, surgeon A might do it this way, surgeon B might do it this way, the other way, but in the paper, they all get lumped into one. And so that's called within study variability. And for figure B, it's called between study variability, which I think we're more commonly associate with this concept. You know, center A does one thing, center B does something else. And so that's in between study. And then, so truthfully, what you want in a very reliable meta-analysis is what you see in figure C, both narrow within study and narrow between study variability, meaning that everyone does it one particular way. And that truthfully is the purpose of protocols. Prospective studies that include protocols are designed to really narrow it down into figure C. And you'll see a lot of systematic reviews, meta-analyses concluding the limitations that prospective studies needed rather than looking at retrospective data. And that's for this reason here in C, to narrow both the within study and between study variabilities. So here in this study, we looked at trigeminal neuralgia, and we looked at the first treatment and so repeat treatment of radiosurgery versus MBD. And you can see here that, you know, in our results page itself, we're telling the reader that there is a significant difference in a short-term pain freedom with this specific p-value less than 0.001. But at no point have we actually mentioned how heterogeneous these studies are. If these studies are highly heterogeneous, then this finding is less reliable than if they're not. And by not recognizing this in the results and in the text, we're not doing ourselves any favor by really highlighting how consistent or non-consistent the studies were within each other and between each other. But in this example here with Dr. Levy, when we looked at neuralgia paresthetica by these various different approaches, you can see I've just highlighted in red the I-squared value. And I always try to really highlight the I-squared value as a degree of heterogeneity. I-squared just means the higher the I-squared value, the more heterogeneous our papers are, and ultimately the less reliable or consistent the results are. And you can see here in this paper, you know, we've listed for every single outcome the I-squared value. And I-squared can vary from 0%, which is the first outcome, which really goes on to indicate how certain or how reliable and how consistent this outcome was between studies, versus something as high as 74% in the other red box, which goes on to show how inconsistent or how highly variable the results were within study. Not every study highlights the I-squared value. I think it's very important because it goes to the fact that these studies are not perfect. These studies are looking at metadata, and as such, you cannot assume them to all be completely stable. Where does this I-squared value then come into? If you remember this grade table here, it actually comes into the consistency. The lower the I-squared value, the more consistent it is, the more certain the outcome. So you can start to see how all these parameters sort of start to interrelate with each other. And so the last pearl for this section.
Victor, does
is,
your
oh,
sorry to
go
bother
ahead.
you. Does your I-squared value reduce your p-value in these studies? For example, you have a significant p-value, but your I-squared, is like super heterogeneous. So, how does it adjust to p-value?
Yeah, it's in some ways a surrogate of each other, and that's the thing. If something is highly variable, then the overall finding has to be very significantly skewed to one result for it to actually not affect it. But in neurosurgery, given that the study numbers are small compared to all these other areas of medicine, I-squared value is in some way a surrogate for, are these consistent? And significant findings tend to be consistent, at least within neurosurgery. And so because of the small cohort sizes, so I-squared is in some way is a surrogate for that.
Another example would be if your effect, so like your relative risk or your odds ratio tended to always be in one direction, but the range was from like 2 to 10.
Exactly.
So the I-squared would be a lot lower, even though in all studies there was a statistical result. So your p-value could be quite low.
Exactly. And because I think one example is blood loss. For example, you can have two different types of surgery, and surgery A can lead to blood loss. And say, for example, one study shows a blood loss of 500 and another one shows a blood loss of 2000. And so you can have heterogeneity in that value, but ultimately they'll all show that one procedure leads to more blood loss than the other. And so you'll still have a significant p-value, even though the heterogeneity or I-squared value will be high. And so I think it's also selective to the summary statistic as well. But that's a great point, an example. The last pearl to talk about, at least that we've put together, is bias, and we'll use tumor examples for this. And it's to look for evidence of multiple bias assessments and post hoc analyses. Ultimately, a lot of these studies, I think people fixate a lot on the numbers, this p-value, this ratio, this, and it's very dangerous just to look at the value itself without understanding whether or not these values were affected by different characteristics. And there are multiple bias assessments to be used and post hoc analyses. And here are just some examples. Publication bias, I think, is a good example of that. As papers get published, there's biases not only within the size of the papers being published, when they're being published, and et cetera, et cetera. And generating these types of funnel plots, or at least seeing evidence of a funnel plot in these types of papers are important, because it's showing you that the authors are trying to consider whether or not one paper is really skewing the overall results. For example, you might have 10 studies that show one thing, and then one paper that is showing completely the opposite thing, which can absolutely skew the results to non-significant if not taken correctly. And a funnel plot is very pictorial, primitive way of just looking at it to see if something is symmetric, as you can see here. And so in a study, you want to be able to see, after they've documented their results and the certainty, that they've done some sort of assessment bias study, and publication bias is one of them. Going back to example before of saying that one study might absolutely skew the results from significance, there's sensitivity analyses or leave one out analyses, which what these do is they look at all the studies that you've incorporated and systematically just remove one. As you can see here, omit this paper, omit that paper, omit that paper, and then redo the calculations. And if you omit one paper and it shows that the overall finding, the odds ratio is completely somewhere else, then you know that's going to have a publication bias effect. And then you have to then, as the author, justify the inclusion or exclusion of this, and you as the reader then have to also make that judgment for yourself, or at least try to look for it. I don't see this type of analysis done that often, which is which really adds to, the statistical confidence of all the findings that they write. And so here's a really interesting example, again, sort of an earlier paper, the idea of repeat surgery of glioblastoma recurrence. Now, when we put this paper together, I thought this was pretty cool. I just learned this new technique of meta-regression, and we included this here, and it's shown as a bubble plot on the right. But what this really does is it's telling you that the significance of repeat surgery is growing over time. So in 2014, the study there did not really show significance, but by the 2018 and all the studies in between, there was a significant trend towards significance. So all of a sudden, this is telling you that, you have to start to incorporate, this trend in your analysis of the results. Should we have included a 2014? Or should we have, at least in the results, divided between 2016 before and 2016 after? Should we have done some publication bias analyses? We should have. And ultimately, when I go through this paper, I realized we didn't. And, if I could do this paper again, that's exactly what we would have done. We've actually shown it evidence of a trend or a bias, and we didn't go on and justify the findings of this result. So that is something that, I look at differently. This here is a paper we did with Dr. Komitar, Dr. Ivan, and we looked at the relevance of this H3K27 trimethylation in meningioma. And you can see here is an example of where we did pretty much everything. And we not only looked at a meta-regression, looking to see whether or not there was any significant differences in terms of all the study characteristics you see listed in that big paragraph. But not only that, we also did all of that bias, quality, certainty assessment. We documented, we looked at funnel plots. We did our size tests with Egger and Beggs tests, which are small study out bias tests that you can do quickly. We also looked at quality with the Newcastle Ottawa scale. And then as I've highlighted earlier, we've looked at the grade criteria as well. And so this here is an example that's very different to the previous example where we've done everything. And I think when you start to read these specific types of papers and you start to try to make your own judgment as to how reliable and how thorough people have been, you've got to look for this. People get caught up in the results. People get caught up in showing that the trimethylation loss is significant within, for recurrence within grade 2 meningioma, without realizing that whilst that's an interesting finding, you have to actually then go ahead and make sure it's not being affected by study size, bias, and quality. And so this here, I think, is a good example of what to do. And I think is something that, I try to do more of as I go on. But having considered all those pearls, the next point is clinical relevance. Evidence-based medicine, and the concept of this is translational actions that will benefit our patients. And the question really is, are these all relevant? Some people could argue that this is just a statistical exercise for publication purposes, rather than actually trying and sometimes forgetting, the point, we're all clinicians trying to, help patients. And so here is an example when we looked at perioperative use of antifibrinolytics for spine surgery. And this, I think, is a good example of something, we were looking at the use of these antifibrinolytics, and we were able to show that there was a significantly lower transfusion need for these studies. That is clinically relevant. That is a question that when you're planning surgery, and as juniors, when we try to, we always, have to make sure there's a type and screen. We have to make sure that there's units ready, or at least in the room. This is an example of something that is with clinical relevance, showing that the use of something can lead to something practical, even for us junior residents as well. So a question like this, I think in the finding is impressive. Something like this, where we looked at, again, going back to this multi-level cervical disease example of hybrid surgery versus ACDF, you can look at the studies we incorporated in this one. And this one here, we had a series of studies with prospective data in the P, retrospective data in the R, and we had some with both. We then sort of coined or tried to use this term hybrid surgery, which was a combination of elements of disc replacement, corpectomy, and fusion. And you can see, looking at this, you see the heterogeneity within this group alone, which now impresses me more than I think I noticed when we put this together. And you can see, for example, the outcomes we found. You know, intraoperative blood loss is always an interesting one. I think we always, you know, want to comment on, you know, a particular surgery or approach saving us blood during the case. But the finding here is, I think, is an interesting practical example. We showed that, you know, after, you know, with hybrid surgery versus ACDF, there was a significantly lower amount of blood loss. But if you actually look at the numbers, 25 mils or 25 cc, in the operating room, it truthfully becomes a question of, you know, when you're in the spine and you're doing multi-level, how significant is 25 cc? And I think, you know, that's an important reminder to have, is that these numbers have to be contextualized. Whilst it is significant, the question is 25 cc blood loss saved, is that clinically relevant? And so again, this goes to the discussion of statistical exercise versus clinical significance for that one. And I'll let you make your own mind up about that. And not only that, but then if studies don't report their pooled means, you don't actually know the context of 25 cc. If blood loss for one approach is 30, then you know, significantly lowering it by 25 cc is impressive. But if the blood loss is 200 and you're lowering it by 1/8, the question then really becomes, again, clinical significance. So when neurosurgical meta-analyses document these results, I think it's important to also look at the numbers and to ask yourself as the reader, is this relevant? And look at all the data. Good papers should include all this data to allow you to make that decision. But where can this go? And I think this is an interesting point. We mentioned this paper earlier, the addition of duroplasty for Chiari 1 in pediatric patients. We published this in, I think it was 2017-18, and that was at the same time, you know, the Park Reeves Foundation or consortium, you know, was really starting to gather momentum in collecting patients. And from that, this year, they actually then published the exact same question, multi-center trial looking at the exact same question we posed 5 years ago, but in a prospective multi-center approach. And I think this is truthfully a great example of, you know, where the limitations of systematic reviews and their analyses can actually be overcome. You know, there are a few examples at the end of all these papers that actually highlight the need for prospective studies, and then actually see the prospective studies get done. I think, you know, it's very easy just to highlight as a limitation and move on. But this, I think, is a great example of how a question, a PCOS question at a meta-analysis level can then equal prospective changes. And this here is a great example of that. And ultimately, we have to start designing the right question relevant to neurosurgery. You know, reviewers will have no issue in telling you that this paper has been done before. And I think whilst it may not be the best way to communicate the idea across, there's no point, you know, trying to reinvent the wheel if a meta-analysis has been done already, trying to look at the quality of the data. So novel PCOS questions are very good. But if you go too novel or too niche, then you won't have enough studies. And then the question becomes, at least with the statistics, is there any value to doing it? If you have a very specific question, you know, for example, trigeminal schwannoma, and you're looking at the efficacy of radiosurgery, and you can't find more than 5 studies, is there any significance in actually trying to statistically pool them? In the field of epidemiology and in the wider evidence-based medicine, there's an argument for at least 14 studies with their various calculations. Neurosurgery, we don't typically have the luxury that I've seen to have 14 questions for every novel neurosurgery PCOS question we have out there. So there tends to be a general gist of at least 5 studies, I think is a good question. And it's truthfully looking for outcomes that can not only influence decision-making, but also be of practical benefit. Again, there's to go too theoretical, it becomes more of a statistical exercise than something relevant to people that practice neurosurgery with our hands. And so I think that's a nice way to really summarize it in this red box, is that there's a lot of data that exists with the advent of more open access neurosurgery journals and the benefit of a lot of things now being electronic. and the continued growth of metadata, there's a lot of data out there. And as long as you have data, you can do an analysis. But the question comes to, do you need to, should you, and why do you? And so it's important to remember that, at least when you're trying to design these questions or critique a question, is there going to be anything clinically actionable that comes out after you pull these? And to start thinking towards the future, what's next? Where is this going? And if we're going to be part of this and we're going to help produce these types beginning, this rise in papers. One option is it keeps going forward. One option is that we keep going up and up and up. More data is available, more techniques are available, the internet's accessible, and it's less time consuming. More novel techniques are coming around, network meta-analyses, meta-epidemiology studies. I'll show you a brief example of that in a second. And so the concept of meta-analysis, you could say, is meta in itself, because what does that truly mean? What is metadata? Is metadata, or is it something else? And so it could keep going, but I wonder, at least in this example here, if the more theoretical you become and the more statistical you become, do you actually forget about the patient you're treating in your office or on the operating table? Another option, what happens is that we plateau off. In the setting of spine, for example, you can keep pushing the boundaries, but even with a spine, there's only the anterior, the posterior, and the lateral. Once you get to that point, you can't create a new sort of axis in that sense. And the same can be said with the brain. And so if you assume we're at a steady state of innovation versus establishment, you could say that the metadata is going to remain constant, which is one example which would lead this to be a plateau. But more interestingly, you could also say that there's not going to be enough novel questions that are going to be asked in the future. That the most novel ones, the easy ones, the low-hanging fruit ones have all been answered. They've all been looked at, and they've all been published. And that we'll see a fall in these studies. You could also argue that new metadata analyses that are not actually involved in the study arise. This includes something like a bibliometric analyses, which have a similar sort of peak to this graph here, just 10 years later, although I suspect that won't go up as high. And finally, journals reduce volume. I think in the last 5 years, the interest in these types of studies within neurosurgery has both risen and fallen, which is very interesting, because the great example of this is where when I started to look into these types of studies, we were able to publish this without without applying stringent guideline checkboxes, which is when I look at my bad examples, possibly why those elements fell through. Now the Cochrane database has a checklist to go through. JNIS mandates you supply a checklist for this type of study, and other journals have completely just stopped accepting these studies because of just the influx and the rise of them. So the fall of meta-analyses in neurosurgeries is also not out of the realm of possibility as well, as people start to question all of them, or in lieu of other more interesting studies or directions journals want to take. And I just want to highlight, that direction of what is too meta. We have the metaverse coming from California now, and we have the meta everything. And the more meta you get, the further away I think you get away from patients. We did this meta epidemiological study looking at GBM biomarkers, and you can see a bubble plot on the right, and it shows that at least with this biomarker CD133, that there was a significant trend in hazard ratio becoming significant over time, and we're really starting now to get further, in my mind, further away from patients. This showed that older studies or original studies that reported CD133 were underestimating the prognostic significance of this biomarker. And what that was really doing was a meta-analysis of meta-analyses. And there's no way to stop. You can do a meta-analysis of, if there's one topic with 10 meta-analyses on it, you can do a meta-analysis of those meta-analyses and then come up with with results like this. And it doesn't stop. It can keep going. And is this actually, are we losing sense of, you know, the patients we're treating here by trying to do all these fancy statistics? And so, you know, I really liken this, I really liken, you know, the outcome of this to, you know, America's Got Talent. You know, who controls the fate of where meta-analyses are going, specifically within neurosurgery? The editors, the journals are key. Obviously, you know, this is an academic publication, and publications happen in the vehicle of journals. And so for the, you know, for meta-analyses to remain a thing, the journals have to continue to evaluate them and accept them. So they're like the judges. People that author them are the auditioners, you know, people, you know, that stand on stage and submit the manuscript and want it to be looked at. But ultimately, you're not going to go to a talent show with a trick you don't think is going to be very good. And so ultimately, authors themselves are not really going to submit papers that they don't think are very good, because no one goes onto a talent show without thinking they actually might have, you know, a trick worth the judge's time. And the question really then becomes, is the author's own judgment of a good trick. You might think you might have the most amazing trick to wow the judges, but it might actually not be very good. And it's being informed, knowing what impresses people. And, you know, neurosurgery is the magic. Neurosurgery is what the authors are showing the judges. You know, as long as there remains an interest in neurosurgery, which is not a question within neurosurgery circles, you know, magic will always be a thing. It will be always something we can show the judges, and it's up to the authors to make sure they put on a good show or a good paper. But, you know, shows like America's Got Talent, for anyone interested, Australia had an equivalent when this show came out. It was called Australia's Got Talent. Very, very creative. That show didn't last. That show lasted a couple seasons, I think, and then it kind of went off the air. But it's impressive to see how much America's Got Talent has continued. And, you know, it's the ratings. You know, you know, a show is not going to last if it doesn't have the ratings. And the use of evidence-based medicine are the ratings in this. You know, journals have their own goals in mind, and as long as they get good ratings, good reads, and the relevance of evidence-based medicine remains pertinent, they're going to continue. So I think, you know, understanding all these facets of, you know, how this these papers get out there are important into, you know, judging the future of these studies. So ultimately, you know, the question I asked at the beginning was, are these studies trash or treasure? And, you know, this is a point I think, you know, where there is always an argument to be made that meta-analyses can be better, no doubt. I've shown examples here where I personally think my own things that I've been part of could be better. And you know, but I also think, you know, meta-analyses are limited. We're not going to, you know, these are not going to change neurosurgical practice. They can inform decision-making, kind of like the cardiovascular drug I showed you at the beginning, but that was only possible based on randomized controlled trials. The use of, you know, to have a significant number of randomized controlled trials in neurosurgery is low. The chance of that happening is low, just because the number of studies and people power and interest and funding needed to create them are not very high. And so beauty is always in the eye of the beholder. I think, you know, the more you know what to look for, the more you know what to analyze and critique, the more beautiful something becomes, or the more trash something becomes. And I think we would all do well, myself, you know, very much included, to understand that, you know, our interpretation of these studies is, you know, are not, it's not everything. There's still things that I'm learning, and I'm sure there are still things everyone is learning as to, you know, the limits of these studies and the use of these studies within neurosurgery. And so meta-analyses in neurosurgery, trash or treasure, they can be both. Beauty is in the eye of the beholder. But I hope that, you know, the more and more, you know, we mandate quality checks, both within the authorship stage, the journal stage, that will definitely see more treasure than trash. And so with that, I'm going to leave this picture up. If anyone has any questions or comments, I think, yeah, I'd love to hear them.
Thanks, Victor. I think that was a great talk. I obviously have some questions. I guess my question is, you know, a lot of these papers, you know, you're publishing these analyses, and, you know, the key thing in that evidence-based algorithm, or that I guess the level of that chart where like a level 1 evidence meta-analysis, you know, but that's usually meta-analysis of randomized clinical trials. And so in neurosurgery, we have these kind of case-based really publication bias prone papers. And most of our papers, I would say 99% of papers published in neurosurgery are have publication bias significant. And those are all the ones we publish out of our own group, out of Miami, out of any group, across the country. And so that, I feel like that publication bias really deters the utility of a lot of these systematic reviews and meta-analyses. And so, I think, and it's probably evident in the journals that are accepting meta-analyses these days, or that, they're less useful, I guess, in that sense. Because my question is, in neurosurgery, is there utility in these meta-analyses of, single surgeon case series from different institutions without control population?
Ashish, I think that's, a really, good question that reviewers challenge all the time within neurosurgery journals. I don't think that, within neurosurgery, these, a single meta-analysis is going to change your practice. You're not going to read something and be like, oh, okay, well, this meta-analysis said this, so I'm going to definitely change my practice. I think for exactly the reasons you said, we're biased within single surgeon series and our inability to do large randomized control trials to a big degree. But I think what they can do is they can highlight bigger questions for higher quality papers to look into. For example, that duroplasty paper with the Park Reeves Consortium, I think, is a great example. But I think that those examples are few and far between. And I think, those examples are being outpaced by journals just publishing these papers. And so the utility of them, dare I say it, is being diluted the more we go, or at least at this rate. With, as you say, less and less examples of high confidence conclusions to translate into practice.
So do you think we should be publishing like more meta-analyses or like less? I guess because there's so many medical students and they have to publish 15 papers to get into neurosurgery, and I'm just curious in terms of your thoughts in terms of what we're doing, like I don't know, it's called the publication dilution or kind of
No, I agree. I think I actually think the responsibility lies with the journals, not with us. I think, it's the journal's responsibility to be very thorough in assessing what they're accepting. But journals have their own intrinsic pressures that they need to meet, and their criteria that they have to, satisfy as well. But ultimately, something needs, for example, if you remember, something needs meta-regression analyses, bias analyses, certainty analyses, quality analyses. They need I-squared values reported. They need all of that. Really to be a good paper, and journals just aren't looking for that, because unfortunately a lot of these papers are being sent to reviewers that aren't aware of that or are not savvy readers, and they're more, a lot of the reviewer comments on these papers I've shown treat it as if it's just a cohort study, which is incorrect. And it's the journal's responsibility to have mechanisms in place, either send it to the right reviewer, send it to the right checklist for us to do. Because ultimately they're the gatekeepers. I think we can try our best, but at Miami we're just one program competing against the world, and I think JNS and Red Journal, they do share some more responsibility than we do to control it.
Yeah. Well, anyway, thank you so much for a great presentation. It was really great how you went through systematically through all the levels of evidence. So thank you again.
Hey, great talk, Victor, and I had to step out for a minute, so I might have missed it. But I wasn't sure if you covered the different programs or packages to do meta-analysis, and if you had any thoughts on that. It seemed like some of them are the Cochrane actually allows you to, they provide a statistical package that allows you to put in the publications, and it sort of partly makes the tables, write some of the paper for
review manager.
Versus R squared versus Stata versus SPSS.
Yeah, Dr. Stock, I didn't actually mention programs. I didn't really try to make this about how to generate the data, but there are programs out there. Review Manager is the one. RevMan is what you're referencing, the Cochrane based one, which is very user friendly, very beginner friendly to begin with, and it pretty much does the statistics for you. But I will say this, as I progressed in my statistical understanding of these things, more robust programs like R, Stata, and MATLAB actually allow you to do a little bit more tweaking and a little bit more of the post hoc small study biases, generate funnel plots, do meta regression, and all those sort of more like post hoc checks that RevMan itself doesn't really do. And I think as we, continue more and more, I think, those are the packages we're going to have to use, because RevMan is good. But, as we continue to strive for higher quality, we need more. But for anyone that's interested in, creating these studies, I think RevMan is a great place to start.
Yeah, and for the people that are interested in doing this, aside from reaching out to, Victor or myself or somebody that has a lot of experience, there's actually online courses that are free that you can take. So when I did my master's, I ultimately added on another course and basically did it myself. But RevMan, the nice thing about it is it basically walks you through it. So the key is understanding the various types of analysis Victor kind of went through, because a bunch of the mistakes in publications and things like that have been made just because people didn't understand those basic elements of heterogeneity or fixed versus random effects, those basic things. But you can learn all that in a pretty short amount of time if that's something that you're excited about. But great talk, Victor.
Yeah, thanks, Dr. Saki. Yeah, by all means, anyone interested, you know how to get in touch with me. All right, thank you, everyone. I guess that ends grand rounds for today.